the surge of dopamine, and the brain will register it as a reward. So now patient will be anticipating in receiving the drug based on the conditioning or the cues that can trigger the drug seeking behavior, such as the smell and look of the drug, whom they were with, and where they were while taking the drug. Uh, Next is the terminology that will commonly be used. For dependence, it is a repeated use of a drug or chemical substance with or without physical dependence. Uh, Physical dependence indicate an altered physiological state caused by repeated administration of a drug, the cessation which will result in specific withdrawal syndrome. And then abuse is use of any drug, usually by self-administration, in a manner that deviates from a proof of social or medical pattern. Misuse is similar to abuse, but usually applies to drugs prescribed by physicians that are not properly used. And then addiction is the repeated and increased use of substance, the deprivation of which give the rise to the symptoms of distress and irresistible urge to use the agent again, and which lead to physical and mental deterioration. So the main difference between dependence and addiction will be people with dependence will experience tolerance and withdrawal without actually being addicted, such as when cancer patients that are using opiate for the pain and they experience withdrawal symptoms, but they did not exhibit any craving or deprivation of the substance, unlike the addiction. Um, Next, for intoxication, it is a transient condition following the administration of alcohol or other psychoactive substance, resulting in disturbance in level of consciousness, cognition, perception, affect or behavior, or other psychophysiological function and responsive. And then withdrawal, it is a substance-specific syndrome that occurs after stopping or reducing the amount of the substance that have been used regularly over a prolonged period. Syndrome is characterized by physiological signs and symptoms, such as disturbance in thinking, feeling, and behavior. For tolerance, it is a phenomenon in which, after repeated administration, a given dose of drug will produce a decreased effect, or increasing larger dose must be administered to obtain the effect observed with the original dose. And then cross tolerance refers to the ability of one drug to be substituted by another, and each usually producing the same physiologic or psychological effects, such as diazepam and barbiturates. And then since DSM-5 replaced the substance abuse and substance dependence disorder from DSM-4 into one same category, which now is called as substance use disorder. And then the diagnostic criteria for substance use disorder based on DSM-5 will be a problematic pattern of substance use leading to clinically significant impairment or distress, as manifested by at least two of the following occurring within a 12-month period. So before I go by one of the criteria, just noted that the criteria remains the same regardless of what substance the patient used. So to make it easier, DSM-5 already simplified these 11 criteria into 4 grouping, which will be easier for us to remember, which is this 4 group. So firstly, the impact control. These are the criteria from 1 to 4, which is substance is often taken in larger amount or over a longer period than was intended. And then there is persistent desire or unsuccessful effort to cut down or control the substance use. A great deal of time is spent in activities necessary to obtain the substance and use or recover from the effect. And then craving or a strong desire or urge to use the substance. And then for the criteria number 5 will be under risky use of substance, which is recurrent substance use in situation in which it is physically hazardous, such as the usage of substance during driving or during swimming. And then substance use is continued despite knowledge of having a persistent or recurrent physical problem that is likely to have been caused by the substance itself. And then the 6 criteria will be under social impairment, where there will be recurrent substance use resulting in a failure to fulfill major obligation at work, school, or home. And then continuous substance use despite having persistent or recurrent social or interpersonal problem, which are caused or exhibited by the effect of the substance. And then the social, occupational, and recreational activities are given up or reduced because of the substance use. And then the criteria 10 and 11 will be under pharmacological criteria, which first, tolerance. patient can have either a need for markedly increased amount of the substance to achieve intoxication or desired effect, or patient can also have may also have markedly diminished effect with continued use of the same amount of substance. And then withdrawal is manifested by either the characteristics of withdrawal syndrome for the substance, which is specific for the substance taken by the patient, or the substance or a closely related substance is taken to relieve or avoid withdrawal syndrome. So if patient have at least two of these following group, we can, with a problematic pattern of substance within a 12-month period, we can diagnose it as a substance use disorder. And then we also need to specify the severity, which is mild when there is present of 2 to 3 symptoms, moderate when there is present of 4 to 5 symptoms, severe when there is present of 6 or more symptoms. And then we also need to specify on the remission, which early remission when there is none of the criteria for the substance use disorder met for at least 3 months, but it is still less than 12 months. And then sustained remission will be none of the criteria for substance use disorder met for at least 12 months. And then if patient is in an environment where the access to substance is restricted, then we need to also specify it, which is in control environment. For example, when patients are closely supervised in the substance-free jails, therapeutic communities, or locked hospital units. And then the difference between substance use disorder and substance induced disorder are the substance use disorder is a pattern of symptoms that are resulting from the use of the substance that individual continue to take despite experiencing problems as a result. While substance induced disorder are the development of a reversible substance specific syndrome due to the recent ingestion of a substance. And then these are the diagnoses associated with the substance classes. And do note here that the caffeine cannot cause substance use disorder. And then tobacco cannot cause substance intoxication. And hallucinogen and inhalants cannot cause substance withdrawal. So I will proceed to the alcohol-related disorder first. So firstly,
Sorry to disturb. Can you go to the previous slide table? Okay. So kalau you tengok from this table, for opioids, kan? Opioid psychotic disorder and opioids, ya. Kalau you tengok sini dia tak put any marks lah for opioids under the column of psychotic disorder, which suggests that opioid do not induce ataupun produce psychotic symptoms lah, ya. But kalau you look at the intoxication and withdrawal criteria of opioids, you'll find out that there is specifier of with perceptual disturbance. Yeah. Dia sebenarnya opioids is possible, dia capable to produce ataupun induce psychotic symptom. Maknanya you can put the diagnosis of opioids induce psychotic disorder, but it is less common. Yeah. So you should not just base on this table only lah. Yeah. Okay, continue.
all right, thank you so much, Prof. I will proceed with the alcohol-related disorder. So, alcohol is an organic substance formed when a hydroxyl functional group is substituted for a hydrogen atom in hydrocarbon. So, the predominant alcohol in alcoholic beverage is ethanol, and ethanol will rapidly enters the bloodstream and reflecting in its high solubility in water, so it distributed throughout the body. Firstly, look at the standard drink. So these are the standard drink of pure alcohol, but it does not reflect the customary servings. So firstly, for beer, it contains about 5% of alcohol. For liquor, it contains about 7% of alcohol. And then for table wine, it contains about 12% of alcohol. And the short of distilled spirits such as gin, rum, tequila, vodka, and whiskey contain about 40% of the alcohol. So alcohol activates GABA, dopamine, and serotonin receptor in CNS, and also inhibits the glutamic receptor activity and voltage-gated calcium channel. So since GABA receptor are inhibitory and glutamic receptor are excitatory, thus alcohol is a potent seen as depressant, which can cause patient to exhibit symptoms of MDD, major depressive disorder. So we need to do thorough history taking to differentiate between the MDD and alcohol-induced mood disorder. For clinical feature of alcohol intoxication will be patient can come with slurred speech, incoordination, unsteady gait, nystagmus, impairment in attention or memory, stupor or coma. While for alcohol withdrawal, clinical features will be hyperactivity such as sweating or diaphoresis, tachycardia or hypertension. And then there will be increase in hand tremor, insomnia, nausea and vomiting, transient visual, tactile or auditory hallucination or illusion, but commonly visual hallucination, and then psychomotor agitation, anxiety, and generalized tonic-clonic seizure. So, based on the diagnosis criteria before, it is the same, where there need to be a problematic pattern of alcohol use leading to clinically significant impairment or distress manifested by at least two of the following occurring within a 12-month. It is the same, so I won't discuss more, but I will discuss about the characteristic of the withdrawal syndrome for alcohol on the next slides later. Okay. And then for alcohol intoxication, these are the diagnosis criteria, and intoxication usually occurs as an episode, usually developing over minutes to hours and typically lasting several hours. So criteria A will be the must be recent ingestion of alcohol, and then criteria B, clinically significant maladaptive behavior or psychological changes such as inappropriate sexual or aggressive behavior, mood lability, impaired judgment that develop during or shortly after the alcohol ingestion. Criteria C will be one or more of the following signs will develop during or shortly after alcohol use, such as the clinical feature before, slurred speech, incoordination, unsteady gait, nystagmus, impaired attention memory, and stupor or coma. And then the sign and symptoms are not attributable to another condition or intoxication by another substance. The clinical feature of alcohol intoxication need to be based on the blood alcohol level from either the serum ethanol or aspired air breathalyzer. So if the blood alcohol level was 0.05% or 0.05 gram per deciliter, clinical feature will be slow motor performance or decrease in thinking ability. 0.1% will be voluntary motor action, and patient usually become clumsy. And then 0.2%, there will be depressed motor area of the brain and emotional behavior are also affected. 0.3, which patient may become confused or may become stubborn, which almost loss of consciousness. And then 0.4 to 0.5%, patient can fall into coma. And if more than 0.5% blood alcohol level in the patient, then the heart rate will be affected. There will be respiratory impairment, aspiration of vomitus, and all of these will lead to the death. Next is the diagnostic criteria for alcohol withdrawal. So criteria A will be there will be cessation or reduction of alcohol use that has been heavy and prolonged in chronic alcohol user. Criteria B will be two or more of the following develop within several hours to a few days after cessation of the alcohol, which is autonomic hyperactivity, such as diaphoresis. Patient can have tachycardia and hypertension, and then increase in hand tremor, insomnia, nausea or vomiting, transient visual, tactile or auditory hallucination or illusion, psychomotor agitation, anxiety, and generalized tonic-clonic seizure. And then criteria C is when the symptoms will cause clinically significant distress or impairment in social, occupational, and work. And then symptoms are not due to other condition or another mental disorder. And then if patient have and then we need to specify if patient have rare instance of hallucination, such as usually visual or tactile, occurring in reality testing, auditory, visual, tactile illusion, occurring as of delirium. So we need to specify if there's a with perceptual disturbance. For alcohol withdrawal, it can be described as 3 stages. However, patient may not experience all the stages. So firstly, stage 1, which is mild in severity. Patient can present with anxiety, tremor, insomnia, headache, palpitation, and GIT disturbance. While stage 2, patient will present it with mild symptoms as above and diaphoresis, and also will cause disturbance in the vital signs such as increase in systolic BP, tachypnea, tachycardia, and mild hyperthermia. And the patient may also come with confusion. And then for stage 3, which is the most severe stage, moderate symptoms will be presented with disorientation, impaired attention, visual and or auditory hallucination, and seizure. These are the we can use Clinical Institute Withdrawal Assessment for Alcohol Scale Revised as a tool to assess the severity of the alcohol withdrawal. So if there is less than 8 points, then it's either absent or very mild alcohol withdrawal symptoms. And then if 9 to 14 points, then a patient have a mild in severity for the withdrawals. And then moderate will be 15 to 20, and severe will be more than 20 points. Patient with delirium, delirium tremens is the most severe form of alcohol withdrawal syndrome, which is a medical emergency. So the clinical presentation involve a triad of symptoms, which based on the name delirium and tremens or tremors. So there will be clouding of consciousness and confusion, vivid visual hallucination, and marked tremor. But delirium tremens is rare and is diagnosed by exclusion, as it only appear in 5% of the patient. So before commencing treatment, we need to screen for other factors that will contribute to delirium, such as subdural hematoma, head injury, Wernicke's encephalopathy, hepatic encephalopathy, hypoxia, sepsis, metabolic disturbance, or any intoxication with any withdrawal from other drugs. So for the treatment, for prevention, we need to give prophylactic benzodiazepine to control the agitation in low dose every 2 to 4 hours until they are out of danger. And then we need to also monitoring the withdrawal signs and symptoms and also the vital signs. If for patient with delirium treatments, then we can give benzodiazepine to control the agitation. So we can give 50 to 100 milligram of chlordiazepam for hours orally. But if patient cannot tolerate orally, then we can give lorazepam intravenously. And then we also need to give antipsychotic for the hallucination. We need to give this too, because if we give benzodiazepine alone, then patient can be more agitated. And if we give antipsychotic alone, then patient can exhibit extrapyramidal side effect. And then IV fluid need to be given and need to correct the electrolyte imbalance to avoid other symptoms, which hypomagnesemia can cause seizures, so we can correct the electrolyte imbalance. And then high calorie, high carbohydrate diet, and supplemented by multivitamins for a patient with poor nutrition intake. And then antipsychotic that can reduce the seizure threshold should be avoided, such as clozapine, because patient with delirium treatments are prone to get seizure. For the management of alcohol use disorder, firstly, the investigation, we can use questionnaire such as audit, alcohol use disorder identification test. And then we can also use CAGE, where patient know that they need to cut down on drinking. And then upon asking about the alcohol drinking, they're annoyed. So annoyance when asked about drinking. And then they feel guilty about drinking, and they need for eye openers the morning after heavy drinking, which for their hangovers. But these are the CAGE are not the diagnostic questionnaire for the patient. And then for blood tests, we can check for blood alcohol level, such as using serum ethanol or aspire air breathalyzer. This is usually more important in the intoxication. And then liver function tests such as AST and LT, GGT, and MCV, because AST and LT ratio will be more than 2:1 ratio, and elevated GGT will suggest excessive long term of alcohol use, and they also need to take a few weeks to return to normal level during abstinence, so we can monitor the alcohol use disorder in this patient. And then for treatment, pharmacologically, we can give benzodiazepine. And then for treating the alcohol dependence, we can give disulfiram, naltrexone, or acamprosate. And then we also need to treat the withdrawal symptoms. If patient have headache, we can give paracetamol, or if patient have diarrhea, we can give loperamide. And then for non-pharmacologically, we should give patient individual counseling for patient to have a goal for yourself, which is abstinence of the alcohol usage. And then for recovery plan, social, environment, and family supports, motivation. Then we can also give cognitive behavioral therapy to teach us the individuals in treatment to recognize or stop the negative patterns of thinking and behavior. And it also help a person to be aware of the stressor, the situation, and the feelings that are leading to the alcohol usage. So these are the other different alcohol-induced disorders, such as alcohol-induced psychotic disorder, alcohol-induced mood disorder, anxiety disorder, alcohol-induced sleep disorder, alcohol-induced sexual dysfunction, and alcohol-induced major or mild neurocognitive disorder. So that's for alcohol-related disorder.
Very good afternoon to everybody. My name is Wu. So I'll be presenting about opioid-related disorders and also stimulant-related disorder, more specifically only touching on amphetamine. Right, so as we go by the definition, we have to make clear, we have to define clearly between opiates and also opioids. Opiates are actually natural opium derivatives. So opium is actually the plant I've shown in the first page. And you can see the seeds over there. Those are called poppy seeds. And these are some examples of natural opium derivative, or we call it as opiates. Examples are heroin, morphine, and also codeine. And whereas for opioids, opioids are actually a mixture of opiates or natural opium derivative and also synthetic opium derivative. So the examples are fentanyl, buprenorphine, and also methadone. Next slide. All right, so next we move on to a classification of opioids. Opioids, actually you can classify them according to the origin, or whether according to strength, or whether to the function, according to the function of opioids. As you can see in this slide, opioids can be divided into two, endogenous and also exogenous. Endogenous opioids are actually produced by in our body, and these are some examples of it: beta-endorphin, enkephalin, dynorphin, and also norceptin. Most importantly, we want to focus on exogenous opioids in this discussion. Exogenous opioids, we can further classify them into three kinds. First one is natural, second one is semi-synthetic, third one is synthetic. So natural opiates, we have some examples such as morphine, codeine, Kibane. And whereas semi-synthetic, we have heroin, and for synthetic, we have methadone, fentanyl, and benzamorphins. These are some of the more common examples. Next slide. Right, this is the second, also third classification of opioids according to strength and function. So as you can see, the more common examples of opioids, codeine, tramadol, they are actually weak opioids, and they are also pure agonists. Whereas for strong opioids, we have fentanyl, methadone, pethidine, morphine. They are also pure agonists. For function, we can divide them, classify them into 4 categories based on the functionality: partial agonist, pure agonist, agonist or antagonist, according to dosage, and also pure antagonists. Next slide. All right, so next we'll be going into the mechanism of action of opioids. So opioids actually binds to the opioid receptor, which we have three kinds, mu, kappa, and also delta. And once it is bound to the opioid receptor, it will be coupled with inhibitory G protein. And once the messenger protein has been bound, you'll send message to three kinds of enzymes, or it'll have three other steps. The first step is to inhibit the adenyl cyclase, and the second step is to reduce the presynaptic calcium influx, therefore decreasing the neurotransmitter release. And the third step is to increase the presynaptic K plus potassium efflux, so that they'll achieve a postsynaptic hyperpolarization, and it will inhibit the postsynaptic potential. All right, next slide. So these are some of the clinical features for those who take opioid. The first we would like to discuss is the route of administration. It can be oral, intranasal, or snorting. And the third one is parental. Parental, we have IV or subcutaneous. So once a normal person takes opioid, they will experience an initial euphoria followed by a period of sedation. So this euphoria is described as a prolonged sexual orgasm. That's why that is what causes the patient to be addicted to it. And it is also associated with a feeling of warmth, heaviness of extremities, dry mouth, itchy face, and also flushing. And whereas there are some physical effects also manifested in patients who take opioids, such as respiratory depression, pupillary constriction. These two are the most important ones. Later I'll discuss about why. And other effects such as smooth muscle contraction, constipation, and also changes in vital signs, changes in your BP, changes in your heart rate, and also body temperature. Right, next slide. So some of the complications of opioid administration. The first one is parental transmission of hepatitis and HIV, because parental administration will cause a patient or cause a person to cause a drug abuser to achieve a very fast effect. So some of them will prefer to use a needle to inject the solution into them. That will cause a higher risk of hepatitis and also HIV transmission through needle prick. Second one is allergic reactions. It will cause anaphylactic shock. Third one is idiosyncratic drug reaction, which will react with monoamine inhibitor, and it will cause a gross autonomic instability, severe behavioral agitation, coma, seizure, and even death. And the fourth one is opioid overdose. Opioid overdose, it will cause a classical triad of coma, pinpoint pupils, and also respiratory depression. And this is an emergency, it will cause death. Next. All right, so this I won't be really discussing because just now Jocelyn has already discussed about it. So the thing I'll be discussing is only criterion 11, which is a withdrawal. Next. All right, specification. I won't. I will be only discussing on the yellow box. All right, because this classification is different from the alcohol use disorder classification, which there is one more specifier, which whether the patient is on maintenance therapy. So this maintenance therapy is actually therapy for the patient to get rid of the addiction towards opioids. So how do we do it exactly? I'll discuss it at the back. Is a kind of treatment. All right, next. So I'll be discussing on the criteria of opioid intoxication. So again, there must be a recent use of an opioid in the patient. Question A. Question B. It'll develop during or shortly after opioid use. So the patient will actually experience significant problematic behavioral or psychological changes. So, for example, initial euphoria followed by apathy, dysphoria, psychomotor agitation or retardation, and also impaired judgment. So, as for criterion C is actually a list of symptoms which the patient with opioid intoxication will elicit. So, the main criteria here is pupillary constriction, and also a patient must have one other symptoms, such as drowsiness or coma, slurred speech, or the third one is impairment in attention. So for criterion D, it's not affected by other medical condition or other mental disorders. So the only specifier in opioid use disorder, as explained by Prof just now, is with perceptual disturbance. So in short, patient will experience hallucination without delirium. Next. All right. Next we'll be discussing on opioid withdrawal. Opioid withdrawal. So criterion A for opioid use disorder is actually it actually differs from other substance use disorder. Substance withdrawal criteria, because normally other criteria you only involve criterion A1, which is a cessation or abrupt stop of opioid use that's been heavy and prolonged. But then for opioid withdrawal, there's a second criteria to criterion A, which is the administration of an opioid antagonist, right? Basically to fight the effect of opioid agonists. And for criterion B, the patient would have 3 symptoms develop within minutes to days after criterion A, or within the abrupt stop or administration of opioid antagonist. The following symptoms are dysphoric mood, nausea, vomiting, muscle aches, muscle ache, lacrimation or rhinorrhea, pupillary dilatation, piloerection or sweating, diarrhea, yawning, fever, and also insomnia. So criterion C basically affects the patient's functioning, and criterion D basically it is not caused by other medical conditions. All right. Next. All right. These are some of the examples of the onset of opioids use, which are morphine. Normally, the onset is faster, 6 to 8 hours after the last dose, and it will peak around 2 to 3 days. And for the duration of withdrawal, normally it will last for 7 to 10 days for morphine and also heroin, but it may also persist up to 6 months. So for lepidolite, it will peak around 8 to 12 hours and last for 4 to 5 days. Methadone, the symptoms will start manifesting in 1 to 3 days, and it'll last for 10 to 14 days. So these are some of the associated features of opioid withdrawal, which is not important criteria for diagnosis according to DSM-5. One of it is restlessness, irritability, depression, tremor, weaknesses, and also nausea or vomiting. Residual symptoms may also persist for months after withdrawal. It includes insomnia, bradycardia, temperature dysregulation, and also craving for opioids. Next. So this is the clinical opiate withdrawal scale to measure the severity of withdrawal effect from opioid. Right. So basically, the criteria are some of symptoms. I think this one you can read it by yourself later. Next. So these are some of the opioid-induced disorders. Opioid can induce depressive disorders, anxiety disorders, sleep disorder, sexual dysfunction, and also delirium. Delirium, whether it is intoxication or withdrawal delirium. Next. Right, so for the investigation for opioids, we actually can do urine toxicology or urine drug screening. Right, so most opioids we also can detect. First detectable 2 to 6 hours after use, and up to 1 to 3 days after administration. So for those fully synthetic opioids, normally more specific tests will be needed. Whereas for IV drug users, you do some screening such as liver function, RPR, hepatitis viral testing, HIV testing, or blood cultures. And also we need to take further history for patients. Next. So as for treatment we can divide into two kinds. The first one is to treat overdose patients or intoxicated patients. So these are the steps to treat overdose patients. To first secure the area of patient, ventilate a patient manually or mechanically until Nexolone administration. And then we need to administer Nexolone at an initial slow rate of 0.8 mg per 70 kg. If there is improvement seen in the patient, improvement wise, it means increased respiratory rate and pupillary dilatation. If you remember just now, I've mentioned the emergency status of opioid intoxication. The triad would be the triad would be pupillary constriction, coma, and also respiratory depression. So basically, if you reverse it, then the patient is improving, and we'll need to repeat administration to prevent opioid toxicity recurrence, because Nexolone is actually a very rapidly acting drug. If there is no response, then we need to repeat the administration after a few minutes. If there is no response after administering a total of 4 to 5 mg, basically normally the presentation of opioid overdose is caused by other causes. It's not caused by opioid overdose. So next. All right, so this is the second type of treatment, which is detoxification or medically supervised withdrawal. So when we go to Wiser Clinic, we can see many patients are taking methadone. Methadone is actually a treatment for opioid use disorders. So the daily dose would be 20 to 30 mg OD and up to 120 mg, because the duration of action of methadone is actually very long, lasts more than 24 hours. And the daily dosing, we'll give a patient daily dosing until patient develops methadone dependency. Right? He'll be more dependent on methadone compared to other kinds of opioids that he was previously taking. Why we want the patient to develop this methadone dependency? It is because it is more easily detoxified than, for example, other opioids agents.
Kejap ya, ni kena correct you lah. The 1, 2, 3, 4, the fourth point lah. Yeah, we never aim to for the patient to become dependent to methadone. There are different phases of treatment of methadone treatment lah. Dia ada induction, stabilization, and maintenance. For example, when we start patient on methadone, of course we have target dose, but our aim first is to stop or reduce the withdrawal symptoms lah. Yeah, and at the end of the day, we wanted the patient to become abstinent or stop taking the drugs lah. Yeah, the duration is depends lah. Yeah, but the guideline says at least patient will require 1 to 2 years of methadone treatment. But because of the psychosocial reason, most of the patient require long-term or lifelong treatment of methadone. Okay, continue.
Okay, understand. All right, so some of the advantages of methadone maintenance, it will reduce HIV spread. It has minimal euphoria effect and also rarely causes depression and drowsiness. And it also allows patients to engage in full employment, and patient can work.
Yang disadvantage ni, the last point ni, I think to get a better understanding, probably you may want to read about the justification of using methadone, which is an opioid for the treatment of opioid use disorder. Can patient is addicted or dependent to heroin or morphine or other type of opioids, but what is the justifications? Why are you giving methadone for treating that problem? So to understand this, you kena baca lagi lah. But I think not fair for you to put this kind of statement like in your slide. These two statement, I think inaccurate lah to me. Yeah.
Okay, understand. All right, next. So these are other kinds of treatments for opioid use disorder, including psychoeducation, CBT, family therapy, support groups, and also social skills training. Next slide. All right, so we've finished discussing on opioid use disorders. So next we'll be moving forward to stimulant-related disorders. So if according to DSM-5, there's two main kinds of stimulant-related disorders: amphetamine type stimulant and cocaine, and also others. So today we'll be discussing more on amphetamine type stimulant lah. So in Malaysia, amphetamine type stimulant or ATS is actually the most commonly used since 2017. Because if you look at the table on the right, originally opioids is the most substance abuse from before 2017. So since 2017, I'm not really sure why, but then people started using more amphetamine. And then the second one is opioid, and the third one will be cannabis. Next slide. So these are some kinds of amphetamine. Amphetamine can be in different forms depending on the structural backbone of it. So the most common one, amphetamine, example is pill coder. But then amphetamine actually is used to treat ADHD and also narcolepsy and even obesity. Second type is methamphetamine. Methamphetamine, it has three forms: solid, liquid, and crystal. So normally when we hear patients saying shabu or ice, it looks like the picture on the right bottom corner. So they'll burn it and they'll inhale it. And the third one is MDA, and the fourth one is MDMA. Next slide. So basically,
Sorry to
amphetamines.
interrupt you. Previous slide, please. The classification, you can classify it into three groups lah. The first one is called classical methamphetamine, classical amphetamine. Things like your ADHD drugs, sibutramine, ephedrine, and so on. The second one, methamphetamine. This methamphetamine can be further divided into tablet and crystalline methamphetamine lah. So tablet includes this pill coder, methamphetamine. Pill coder ni is methamphetamine. Yeah. And the third group is MDMA, which include ecstasy. Yeah. So pill coder, shabu, ice is under methamphetamine, the second group. Continue.
Okay, I understand, Prof. Later I will change. So the mechanism of action of amphetamines, will actually induce a sympathetic effect, and through potentiating the effects of neurotransmitters such as serotonin, dopamine, and also norepinephrine. And it will actually cause a release of dopamine in the mesolimbic pathway. So it will cause because mesolimbic pathway is involved in the reward pathway. So patient will feel more rewarding after taking amphetamines. Basically, the patient will feel that it, their performance is increased, and also it will induce an euphoric feeling, causing increased energy, a state of alertness, and also euphoria in the patient who takes amphetamine. At the same time, there's an increase in confidence and impulsivity, and a decrease in judgment. Next. Right. So these are some of the complications of amphetamine. we can divide them into physical and also psychological complications. So as for physical complications, you can divide them into whether it is life-threatening or non-life-threatening. Basically, for cardiovascular, it can cause cerebrovascular accidents, myocardial infarction, or severe hypertension. As for gastrointestinal, it can cause ischemic colitis. Normally, only at high doses, it will manifest in central nervous system, including muscle twitching until tetanus. Whereas immune system, patients will be more prone to getting HIV and also hepatitis. Non-life-threatening complications is listed as below. I think you can read it yourself. Whereas for psychological complications of amphetamine, it will include restlessness, dysphoria, insomnia, irritability, hostility, confusion, symptoms of anxiety disorders, and also psychosis in the patient. Next. Right. This stimulant use
This one can
disorder
skip lah, same thing, right? Can, let's keep
is
SUD.
actually same. Right, as for specifier, sorry, to previous slide, for specifier, we have to specify what kind of substance is used. The only thing different is in the red color box. So next. Right, stimulant intoxication. Criterion A, a recent use of a stimulant. Criterion B, developed shortly after stimulant use. So actually, it's the same criteria as opioid intoxication. Criteria C, at least 2 or more symptoms will have to be developed in the patient. First one is tachycardia or bradycardia, pupillary dilatation, elevated or lower BP, perspiration or chills, nausea or vomiting, weight loss, psychomotor agitation or retardation, muscular weakness, respiratory depression, chest pain or cardiac arrhythmia, confusion, seizure, dyskinesia, dystonia or coma. So criterion D is the same thing, not caused by any other medical condition. So for specifier, we have specify the substance use and also whether it is with perceptual disturbance. Next. All right. Next is stimulant withdrawal. Again, criterion A is the same thing. Whereas criterion B, the stimulant withdrawal symptoms develop within a few hours to days after taking. After stopping. At least 2 of the physiological changes in patient plus dysphoric mood to diagnose as a stimulant withdrawal. The physiological changes include fatigue, vivid or unpleasant dreams, insomnia, hypersomnia, increased appetite, or psychomotor agitation or retardation. So criteria C and D is the same thing. Next. So these are other stimulant-induced disorders. Stimulant can induce psychotic disorder, mood disorder, anxiety disorder, OCD, sexual dysfunction, also sleep disorder. Next. Right, for investigation, we can do urine toxicology. So cutoff point is 1,000 nanogram per ml. And also we can assess the severity of withdrawal effect. So this is a scale and also the levels of severity. Okay, next. Next, for treatment, also rehab, pharmacological wise, you can give the patient antipsychotic if the patient has psychotic symptoms for first few days. And after the psychosis of the patient resolve, you can give diazepam to treat agitation, also hyperactivity. As for if the patient develop comorbidity, which is depression at the same time, you can give antidepressant, which is bupropion, after the withdrawal. More pharmacological wise, you can give the patient counseling and also CBT. That's it.
Okay, the treatment of ATS, pharmacological treatment. Yes, if you open up guideline, there is no specific treatment, no specific pharmacological treatment for ATS dependence lah, or ATS use disorder. But isolated studies have shown effect of different class or group of medications like antipsychotic, antidepressant, and stimulant, and few others lah. As for ourselves, USM, Wiser, we have done a collaborative study with Yale University, US, testing 4 different class of medication to be used for treatment of ATS use disorder. Those medications are antipsychotic. We use paliperidone, antidepressant, mirtazapine or Remeron, which is NASA group, and then minocycline, which is antibiotic, and also atomoxetine, which is ADHD medications lah. Yeah, so you can check evidence from scientific studies lah for this pharmacological treatment of ATS dependent. Okay, thank you, Jingwo. Next one.
Okay, Assalamualaikum. My name is Afifa and I will proceed with the last part of the presentation today, which include cannabis-related disorders and ketum. First is cannabis-related disorder. Next. Okay, cannabis or marijuana is the most widely used illegal drug in the world, with an estimate about 19 million users in 2012. Cannabis preparations are obtained from the plant Cannabis sativa. The plant occurs in both male and female form, and the female form contain the highest concentration of more than 60 cannabinoids that are unique to the plant. Delta-9 tetrahydrocannabinol or Delta-9 THC is the cannabinoid that is primarily responsible for the psychoactive effects of cannabis. The plant is usually cut, dried, chopped and rolled into cigarettes or may be mixed with tobacco as a joint in pipe. And also it can also may be mixed as hashish in food or in certain cases baked in brownies and cookies, or may also be brewed as a tea. Okay, some also turn cannabis into hashish oil that can be used in smoking substances. Some popular street names of cannabis include ganja, weed, dope, hashish, pot, grass, sayu, joint sticks, and tarak daun. Based on 2012 National Surveys on Drug Use and Health, an estimated 19 million persons aged 12 years and older had used marijuana in the past month. Of this age group, 2.4 million initiated use within last year, and 57% of which initiated use before age of 18 years. The rate of past years and current marijuana use by males almost twice the rate of for females overall among those aged 26 and older. Okay, next. Okay, there's some 5 diagnostic criteria. It is similar with the diagnostic criteria of other substances presented just now. So we're gonna skip on these slides. Okay, next. Next. Okay, we take a look at the diagnostic criteria of cannabis intoxication. We focus on criteria C. To diagnose cannabis intoxication for criteria C, we need 2 or more of the following signs and symptoms developing within 2 hours of cannabis use, which include conjunctival injection, increased appetite, dry mouth, and tachycardia. As for criteria A, B, and D are similar to other substances. Okay, next. Okay, for diagnostic criteria of cannabis withdrawal, we can focus on criteria B, which is 3 or more of the following signs and symptoms developed within approximately 1 week after criterion A, which include irritability, anger or aggression, nervousness or anxiety, sleep difficulty, for example, insomnia and having disturbing dreams, decreased appetite or weight loss, restlessness, depressed mood, followed by at least one of the following symptoms, which are abdominal pain, tremor, sweating, fever, chills or headache, which cause significant discomfort. Okay, next. Okay, other cannabis-induced disorders include cannabis-induced psychotic disorder, cannabis-induced anxiety disorder, and also cannabis-induced sleep disorder. Okay, next. Okay, treatment of cannabis use rests on the same principle as treatment of other substance abuse, which are abstinence and support. Abstinence can be achieved through direct interventions such as hospitalization or through careful monitoring on an outpatient basis by the use of urine drug screening. Support may be achieved through individual, family, and group psychotherapies. Some example of psychotherapies that we have here include cognitive behavioral therapy, where patients learn about coping skill, manage stress, and change thought that caused them to take ganja. Then motivational enhancement therapy, where patients build and strengthen motivation to change their behavior. And lastly, contingency management. This management refers to a type of behavioral therapy in which patients are rewarded for evidence of positive behavioral changes. For this case, for submission of drug negative specimen, when it is collected multiple times every week. So this kind of method help patient with abstinence. Okay, next is pharmacological intervention of cannabis use disorder. For some patient, and anti-anxiety drug may be useful for short-term relief of withdrawal symptom. For other patient, cannabis use may be related to an underlying depressive disorder. And this group of patient may respond to specific antidepressant treatment. And also giving the oral cannabinoid agonist, which is oral THC, can decrease both withdrawal symptom and cannabis craving. Okay, next. Okay, now we move on to ketum or kratom use disorder. Okay, for introduction, ketum leaf or its scientific name, Mitragina speciosa, comes from the ketum tree, which is a plant of the family Rubicae. Family Rubicae is the same family as the coffee tree and is found abundant in the northern states like Perlis, Kedah, Penang, Perak, as well as the east coast of Peninsula Malaysia, which are Pahang, Kelantan, and Terengganu. Traditionally, ketum was mostly used as a stimulant by Thai and Malaysian laborers and farmers to overcome the burdens of hard work. They usually chew the leaf to make them work harder and provide energy and also pain relief from the muscle strain. Okay, the main active ingredient in ketum leaves are mitragynine and 7-hydroxymitragynine, which are both psychoactive alkaloid. These two compound interact with opioid receptor in the brain, and then producing sedation, pleasure, and also decrease pain. Mitragynine also interact with other receptor system in the brain to produce stimulant effect. Ketum leaf usually are boiled to produce a ketum drink, and it can also be abused by oral ingestion in the form of a tablet, capsule, or extract. Ketum leaf may also be dried or powdered and ingested as a tea, or it may also be chewed. Okay, the common street names, as we can see, include biak-biak, ketum or kutum, which are common in Malaysia, and while in Thailand, itang and kakuan. Okay, next. Okay, the effects of ketum in humans are mostly dose dependent. At low dose, about 1 to 5 gram of ketum, ketum will produce stimulant-like effect. And this effect are usually felt within 10 minutes and last for about 60 to 90 minutes. And the primary stimulant-like effects of ketum are said to be almost similar to amphetamine but less intense. And the effect include increased energy and alertness, decreased appetite, increased sociability, and heightened libido. And if patient take moderate to high dose, which is about 5 to 15 gram of ketum, it will produce primarily opioid-like effects that last for several hours. And as reported by users, the euphoric high induced effect by the drug is reportedly less intense compared to other opioid drugs. And the effect include analgesia, drowsiness, calm, dreamlike mental state, cough suppression, reduction in symptoms of opioid withdrawal. And if a patient take ketum greater than 15 gram, usually they have effects similar to high doses of opioid, which include extreme sedation and in some cases a loss of consciousness. Okay, so far ketum use has not been put in the DSM-5 yet, and the effect taking ketum are mostly based on users' report. And there are several side effects reported, that are associated with ketum use, and it range in severity from inconvenient to dangerous. And the side effects are dependent on the, as I said before, dependent on the dose taken. And the side effects are similar to those found both for stimulant and also opiate drug. The side effects include pupillary constriction, facial flushing, tremors or loss of motor coordination, constipation, sweating, dizziness, nausea and vomiting, itching. And also unusual effect on users on chronic high dose ketum users include hyperpigmentation or darkening of facial skin, anorexia and weight loss, and also psychosis. And as we can see, serious toxic effect appear to be rare. So ketum intoxication is rare, reportedly rare. However, the most serious toxic reaction that have been reported is associated with high dose of ketum, which is more than 15 grams, and the effect have been characterized by seizure. Okay, and then for withdrawal, dependent users of the drug usually suffer physical withdrawal symptoms similar to those of taking opiates if they stop taking it suddenly. And some of the symptoms include irritability, sweating, nausea, high blood pressure, diarrhea, runny nose, joint and muscle pain, insomnia, and intense craving. So these symptoms are almost similar to opioid withdrawal symptom. Okay, next. Okay, so there are no specific medical treatment for ketum addiction. So some people seeking treatment have found behavior therapy like cognitive behavior therapy to be helpful. And since ketum dependence is new and relatively uncommon in West, so there are no specific treatment regime for withdrawal and addiction. However, there are some scientific literature mentioned about a few medications that are useful in treating patients with ketum addiction and managing their withdrawal. So these drugs are similar to those used for opiate addiction, such as methadone. And if patient develop hallucination, then we may also give patient antipsychotic. Okay, that's all from me. Thank you.
Thank you, Avifa and all the presenters. Any question for presenters? Ada soalan? Lapar dah, hypo dah. Okay, tak apalah. To sum up ya. First one, alcohol. Yeah, alcohol tadi. Dia when you talk about substance, yeah, this alcohol and illicit drug ni, pertama kena bagai. You need to know the substance. Yeah, alcohol. There are 3 different group. Kan, secara generalnya, alcohol ni you can divide into 3 different groups lah. The beer, wine and spirit. Yeah. Bila I kata kena bagai ni, tadi you mention about the content or internal content of different type of alcoholic drinks ni lah. You tak masukkan audit dalam you punya ni. Kalau you tengok audit assessment, which is a scale that you use to assess severity or degree of alcohol use disorder, yeah, or alcohol addictions. Bila you assess patient, and you ask question to the patients, when you take history of patients alcohol consumption, kita bukan tanya dia guna apa ataupun the most important thing in your communications when you take history, when you assess patient alcohol consumption, you need to use a standard measurement. You kena quantify. Yang ni bukan sahaja untuk alkohol tapi bagai ketum tadi pun kita tak kata berapa gram you makan, no. Dan kena bagai ni juga you need to know, you need to familiarize with the local terms lah, street names of the drugs lah. Yeah. Macam heroin di Kelantan dipanggil poteh. Pil kuda, methamphetamine, the yaba pills, they call it pil kuda ataupun buah and so on lah. Yeah. Alcohol ni you need to know the formula to calculate standard drink. Yeah. Ini you baca lah tak nak cerita banyak-banyak ni, you baca apa dia formula to calculate or to determine standard drink so that you can quantify and then you can determine what are the level of patient's alcohol consumption. Whether your patients, kalau based on audit, they classify into four level lah. Whether your patient is a safe drinker, hazardous drinker, dangerous drinker or alcohol dependence. Yeah. Okay, itu yang pertama. In terms of medication, alcohol, in Malaysia, we don't have, you mentioned 3-4 different medication or drugs, yeah? Pharmacological treatment for alcohol use disorder. You mentioned acamprosate, apa nama, naltrexone and also disulfiram, yeah? Unfortunately, we don't have all these medications lah, yeah? Kalau ada pun probably naltrexone lah, but naltrexone ni dia ialah opioid antagonist, yeah. Yang ni some center, I mean some government hospital they have, but dulu kita bawa masuk naltrexone ni untuk rawatan opioid dependence lah, yeah. Disulfiram, acamprosate yang first line treatment for alcohol use disorder in other countries lah, in Western countries lah, yeah. In USM, I use topiramate, yeah, topiramate, which is antipsychotic. So you baca lah yang tu. Next substance yang tadi tu opioids. Opioid ni tadi saya suruh you faham tentang the justification of giving or using methadone to treat heroin use disorder lah, yeah. And another related issue ialah decriminalizations of drug addictions. Dan kebanyakan bila kita kata drug ni opioids lah, ya. Walaupun sekarang ni in Malaysia kalau satu table yang ditunjuk satu data yang ditunjuk daripada ADK tu, nombor satu the most abused drug in Malaysia now is ATS, not opioid anymore lah, ya. We have I think boleh kata successful to control heroin abuse or heroin use in Malaysia, and also successfully control the harm related to the alcohol abuse lah in Malaysia. Specifically the HIV infections lah, yeah. So in Malaysia now HIV ni dia punya transmission ataupun dia punya infections come from the MSM lah, the sex sexual activity rather than IVDU. Okay, and then you pergi kepada ATS tadi dah sebut dah sikit, ya. So decriminalization ni kalau tambah satu lagi, you kena faham apa dia definition of addictions. Kenapa kita consider addiction ni as a brain disease ataupun medical illness, ya. And kalau you tak agree with this concept, then you have to understand this concept so that you can agree with providing treatment rather than punishment to those patients yang suffer from or have problem dengan drugs lah. Yang cannabis tu related issue and important issue, probably kalau exam tak tanya lah you punya level, tetapi kalau you read newspaper and social media, people talking about CBD, yeah, CBD and THC, kan. Dia related dengan decriminalization, but this time is medicalizations, yeah. Apa dia CBD, apa beza CBD and THC, and beza tu in term of the effect, yeah. Both THC and CBD are cannabinoid, yeah. They comes from this sativa plant lah, yeah. Tetapi apa beza dia? Apa dia punya effect, especially the medical effect of CBD, yeah. Then baru you boleh faham or hence agree for with people who are promoting to use CBD for medical purposes lah, yeah. Okay, and the last one is kratom lah. Kratom tadi saya cakap tadi kena bagai. Kita bukan bercakap tentang berapa gram, berapa kilo daun patient use. When you assess patient who use or abuse kratom ni, you need to know how they prepare, how much in term of the volume, yeah, berapa ml or berapa liter they use ketum lah. Preparation tu sometimes they can tell you how they prepare, what they mix into the ketum drink or ketum juice, but sometimes if they buy the ready juice, they can't tell you lah, yeah. Tetapi biasanya dia boleh beritahu you, walaupun tak boleh beritahu berapa banyak daun, berapa kilo daun dia guna untuk produce the juice, but they can tell you lah whether any addictive were add into the drinks or not lah, yeah. And management, the last one, yeah, management. Kalau kira the recognized treatment, yeah, pharmacological treatment, kita ada is only for opioids, which include buprenorphine, partial agonist, and also full agonist, which is methadone lah. Cuma buprenorphine ni, Suboxone ni, saya bagi untuk yang private patients lah, yang paying patients lah. For patients yang tak berbayar ni, kita bagi ubat yang percuma like methadone lah. Other than that, heroin, alcohol, standard treatment is benzodiazepine, especially for the treatment of the withdrawal symptoms, yeah, but not for the alcohol use disorder, yeah. Alcohol disorder tu yang tadi kita sebut tadi itulah, acamprosate, disulfiram and so on lah, yeah. Whereas for the ATS, cannabis and ketum tadi, yes, no standard treatment. But based on kita punya knowledge on the effects and mechanism of action of those substances, and scientific studies, kita bagilah treatment, kita berguna certain medications lah. Saya rasa itu saja. You all pun penat nak prepare untuk next class. Year 5 ada student yang positif. Year 4 beringat-ingat, I tak tahu nak cakap macam mana, tapi kena practice SOP kan. Dalam masa terdekat ni, kalau you rasa you have contact with the year 5 student, so I would like to suggest you to do online class lah. Tak mau jadi benda ni become out of control, nanti dah spread to the lecturer, jadi susah pula, yeah. If there is no more question, kita akan end the class and I'll see you again in my mentee in the clinic. Okay, thank you very much. Assalamualaikum. Bye.